Okay, you can start now.
Good morning, everyone. I'm Dr. Shreya Natraj. Today I'll be speaking on when optic atrophy meets papillary edema, a case of pseudo-Foster-Kennedy syndrome. Pseudo-Foster-Kennedy syndrome is defined as one-sided optic disc edema and optic atrophy in the other eye, but without the presence of intracranial mass lesion. Whereas Foster-Kennedy syndrome refers to a constellation of findings associated with tumors of the frontal lobe, resulting in optic atrophy in the ipsilateral eye, optic disc edema in the contralateral eye, with associated ipsilateral anosmia. The purpose of this report is to present a case of pseudo-Foster-Kennedy syndrome and to highlight its clinical features and its diagnostic challenges. Methods: a 50-year-old gentleman with a known history of hypertension and diabetes presented with complaints of sudden painless diminution of vision in the right eye for 6 months and some visual disturbances in the left eye for 1 week. There was no positive history of headache, double vision, pain, emotional disturbance, or jaw claudication. Clinical evaluation of visual acuity, color vision testing, autorefraction, anterior and posterior segment examination, and optical coherence tomography imaging was performed. Results: the best corrected visual acuity in the right eye was counting fingers close to face, and left eye was 6/9 with the autorefraction readings of plus 0.5 diopters per equal in both eyes. Color vision testing using the Ishihara chart showed 0/15 plates in the right eye and 15/15 plates in the left eye. Anterior segment examination revealed a relative afferent pupillary defect in the right eye and a bristly reactive pupil in the left eye. Dilated fundus examination demonstrated clear media in both eyes with a pale disc suggesting optic atrophy in the right eye and blurring of disc margins in the left eye suggestive of disc edema with a good foveal reflex noted in both eyes. OCT of the optic disc showed a reduced retinal nerve fiber layer thickness in the right eye and increased thickness in the left eye, correlating with the disc edema. A neurological consultation was obtained and MRI of the brain was performed in which there was absence of any intracranial mass, which confirmed the diagnosis of pseudo-Foster-Kennedy syndrome, most likely due to sequential anterior ischemic optic neuropathy. Blood tests were done for erythrocyte sedimentation rate and C-reactive protein and were within normal limits. Pseudo-Foster-Kennedy syndrome is a diagnosis of exclusion with both true and pseudo-Foster-Kennedy syndrome presenting with visual loss with optic disc swelling in one eye and optic disc atrophy in the other eye. So hence neuroimaging plays an important role in differentiating between the two conditions. The most common etiology for pseudo-Foster-Kennedy syndrome is bilateral ischemic sequential anterior ischemic optic neuropathies, either arthritic or non-arthritic. Non-arthritic AION is more common. The pathophysiology is two separate attacks of visual loss with optic disc edema that has resolved to optic atrophy in one eye and a new episode of anterior ischemic optic neuropathy in the other eye. The risk factors are hypertension, diabetes mellitus, high cholesterol, history of smoking, and sleep apnea syndrome. In our case report also the patient had risk factors of hypertension, diabetes, and high cholesterol. Treatment is medical therapy which depends on the etiology. In non-arthritic AION, mainly it is antiplatelet agents like aspirin and cerebral vasodilating agents. To conclude, distinguishing between true and Foster-Kennedy syndrome is critical as their underlying causes and management strategies differ significantly. Accurate ophthalmic evaluation and timely neuroimaging with interdisciplinary collaboration is essential for its accurate diagnosis and effective patient management. These are my references. Thank you.
You want to ask any questions?
What do you mean by effective patient management in this case?
If we suspect it is a case of if there's pseudo-Foster-Kennedy syndrome or Foster-Kennedy syndromes, for better management, it's early as possible we should refer to a neurologist and get an MRI done to rule out if there's any frontal lobe tumors or something. So it's better if they go to a neurosurgery consultant and go for it. And if it's any arthritic AION cases, then it's better to start IV methylpred as early as possible.
So in this case, was MRI or neuroimaging done?
Yes, ma'am. Yeah, MRI was done.
What was the risk factor in your patient for non-arthritic AION to happen?
Ma'am, he had risk factors of diabetes, hypertension, and also he also said sleep apnea syndrome, but not confirmed.
Was it uncontrolled diabetes, hypertension?
Uncontrolled diabetes and
Uncontrolled.
hypertension.
Good, well done.
Thank you.
Please go.
Has Dr. Mayuri come? Yeah, ready? First one, sir. First two demonstrations.
No, this one. This is the number.
Number one.
Usko bola.
Good afternoon, everyone. My name is Dr. Aris Mayuri. I'm a
Speak closer to the mic.
Good afternoon, everyone. My name is Dr. Aris Mayuri. I'm second year PG student. My presentation is dry eye status in type 2 diabetes and its association with severity of diabetic retinopathy. We all know that diabetes nowadays is very common, and in ocular surface disease such as dry eye is frequently present in patients with diabetes mellitus, either symptomatic or asymptomatic. It can cause mild discomfort to serious corneal complication affecting the visual quality of life. The study is to detect the dry eye status in type 2 diabetics and assess its association with severity of diabetic retinopathy. My aims are object to estimate the proportion of patients with dry eye disease in type 2 diabetes patient and determine the relation with severity of diabetic retinopathy. We take 12 month of study from July 2024 to July 2025. 100 patients are taken, and we taken mostly patients who are present more than 40 years and type 2 diabetic patients. My inclusion criteria: all patients with type 2 diabetes and patient with age of more than 40 and patient willing to participate. And all the exclusion criteria are severe allergic dry eye disease like vitamin A deficiency, Stevenson syndrome, and VKC, herpetic eye infection, and mammalian gland dysfunction, and post-ocular mechanical burn. Patient receiving topical treatment such as alpha agonist and dry eye also exclusion criteria, and patient with history of ocular surgery such as cataract and glaucoma also exclusion criteria, and contact lens wear also. So this is my result, where we see that p-value is more than 0.01%, and it is the significant status between dry eye status and diabetic retinopathy. These are patients we taken, mostly they are proliferative diabetic retinopathy and severe NPDR are mostly present with dry eye, and in non-diabetic and mild moderate discomfort are present. Dry eye is less than mostly in less in severe and proliferative diabetic retinopathy. This is the graphical presentation, and this is the result duration of dry eye diabetes versus dry eye, where we see that 50.9% in more than 5 years are present with this dry eye, 77.8% in 6 to 10 years, and 84.6% in 11 to 5 years, and 77.8% in more than 15 years patients who are present with dry eye in that result. This is the graphical representation between age and duration of the dry eye. In OSDI grading and dry eye, majority with moderate to severe OSDI grade had dry eye 94.2, 91%, 91.7%. In normal eye, so only 26% of 26.7% of prevalence. In normal eye, dry eye present 26%, and moderate cases is 100%, and moderate dry eye is 94%, and in severe cases is 91.7%. Absent, as it's mentioned it below. This is the graphical presentations. In tear-filled breakup time and dry eye, 95.9% of mild to moderate severe cases in tear-filled breakup type, and 85.7 in severe TVT grade, and in normal TVT had only 27.3 dry eye prevalence, that is less than 0.001. In this is normal and mild to moderate and severe cases, more than 10 seconds of tear-filled breakup type is seen in dry eye present 27.3%, where absent in 32 and 72.7%. In mild to moderate cases, it's 47, and severe cases is 80.5% of severe dry eye present. This is the HV1AC significance in patients with higher dry eye patients, dry eye present in more in mean H1C is high in 9.3, where dry eye absent in mean H1C is 7.9%. So my conclusion is patient with type 2 diabetes have higher prevalence of dry eye evaluation of diabetes patient using OSDI questionnaire can be helpful in identify of dry eye in early stages. Significant association was noted between dry eye disease and the duration of the diabetes. Significant reduction in tear film breakup time and simmer test was found in diabetes, and especially patient with those with retinopathy, and positive association was observed between severity of retinopathy and dry eye. Patients with advanced diabetic retinopathy are increased risk of developing ocular surface complication. Hence, our study insists that clinical evaluation of dry eye should be an integral part of ocular examination and diabetic patients. Thank you.
Good. You consider this association just a coincidental, or there is a causal relation between dry eye and retinopathy?
You speak over the mic.
Do you think they are associated by coincidence, or there is a causality?
Sir,
You know, there is a way to assess, statistical way to assess whether it is a cause and effect relation or it is just a coincidental. Did you do that?
it's a statistical, sir. We take 100 patients and we evaluate each patient.
No. You have shown me the percentage.
Yes.
But there is a way to calculate whether it is just a coincidental association or there is a causal relationship, causality relationship
It's a cause and relationship.
between dry eye and...
And dry eye and diabetic patients who are present with diabetes.
So if any patient comes who has a history of diabetes, you check for dry eyes, and if it is there, then chances are very high that he will have retinopathy. Is that what you are saying?
No.
No, if that is not the thing, then the relation need not be causal.
Yes.
Just an associated finding.
Okay.
Because the eye ages from front to back at the same level in a diabetic. You understand what I am asking the question? So you need to associate the two more carefully than what you have done. Good, well done.
Thank you.
How did you manage the patients who had, dry eye in your patients? Was it a routine management or?
It's we follow up the patients in the routine management. We also done the routine management and also tell the patient to follow within 3 months or every 6 months to check.
Can it be related to diabetic autonomic neuropathy in the patient because it correlates with the severity of retinopathy as well?
Yes. Thank you, ma'am.
Next, I would like to call Dr. Vikas Sharma.
Good morning, everyone. Today I'll be presenting a rare case of bilateral optic neuritis in an unusual etiology. Optic neuritis is an inflammatory demyelinating disorder of optic nerve. It has got multiple etiologies. However, multiple sclerosis is the most common. My patient is a 37-year-old female who presented to us with sudden onset diminution of vision in the right eye, which progressed over next 2 days. She also had mild pain in both eyes preceding the onset of diminution of vision. There was no any other ocular complaints. Her positive past history was frequent use of lubricating eye drop. She was a non-diabetic since last 6 years. There was no history of recent febrile illnesses, chronic use or cessation of any drug, recent weight loss or weight gain, any other long-term illnesses. Her general and systemic examination, including CNS examination, was within normal limits. A positive finding in her extraocular movement was she had mild pain in adduction and elevation of the right eye. She had dyschromatopsia in both eyes. Her contrast sensitivity was decreased and RAPD was present in the right eye. Her fundus examination revealed bilateral disc edema, which was asymmetrical more in the right eye. Her visual field showed superior latitudinal defect in the right eye, and left eye had few scattered defects. At this point, we have a young female patient with sudden onset diminution of vision with painful ocular movement and bilateral disc edema. At this stage, our provisional diagnosis was bilateral optic neuritis, query MS or neuromyelitis optica spectrum disorders. We promptly started our patient on pulse IV methylprednisolone 1 gram for 5 days while we were waiting for blood investigation results. Though her blood investigation result did not show us any raised inflammatory markers, her VEP was prolonged in the right eye. Her CSF analysis for MS was also within normal limits. NMO spectral disorders antibodies in the form of aquaporin 4, anti-NMO, P-ANCA and C-ANCA were also negative. We did her MRI brain and orbit, which revealed mild atrophic changes in the supratentorial brain parenchyma, which was not consistent with her age. There was sign of hyperintensity in T2 image in the retrobulbar or intraorbital part in the right eye, and similar enhancement in the left eye, suggestive of optic neuritis. There was a finding of partially empty sella, which is associated with idiopathic intracranial hypertension. However, due to painful optic neuritis without risk factor of IIH, it prompted us to further investigate this patient. We ordered anti-nuclear antibody qualitative analysis, which reveals SSA positivity. This further led us to reconsider her history of frequent use of lubricants and possibility of Sjogren's syndrome as an etiology of optic neuritis. We did her dry eye workup, which came out to be severe dry eye disease in both eyes. Since we had already started her on IV methylpred, we shifted her to oral steroid in topical doses. We also started her on tablet azathioprine 50 mg OD for 1 week, followed by BD doses after a week. Her lubricants in the form of 1% CMC was continued. In follow-up period, at the 6th day after the presentation, she had improved in her visual acuity to 618 in the right eye and 6 in the left. Sjogren's syndrome is a chronic autoimmune exocrineopathy. Hallmark is granular involvement of lacrimal as well as salivary gland. It has got typical manifestations of xerostomia and keratoconjunctivitis sicca. However, in our case, the literature suggests there are few cases of optic neuritis which can precede these typical symptoms and which makes it a diagnostic challenge. Prognosis depend on whether it is associated with any other neuromyelitic spectral disorder. Then the relapse become more, the attacks become severe, it is more morbid, and long-term immunosuppression are needed for those cases. However, still, if it is singly associated with Sjogren's syndrome, it is still prone to recurrence. However, the usual catastrophe is less visually impaired. To conclude, optic neuritis can be rare, but a serious clinical presentation in patients of Sjogren's syndrome without its cardinal symptoms. Hence, it is important to have a high threshold of suspicion, especially in patients of bilateral optic neuritis. These are my references. Thank you.
So what gave you the clue that you have to check for the anti-nuclear antibodies in your patient?
Yes, ma'am. Since the MRI report had typical signs of optic neuritis, there was inflammation, there was hyper intense lesion in the T2 image in the right eye. This led us to think, and since there was no as such associated history of IIH also, so this led us to think there must be something else. And since all the rest of the antibody profile like aquaporin, anti-MOG
So first you had done the regular battery of investigations.
Yes,
once
yes,
it turned out negative.
yes.
So what other manifestations of Sjogren did your patient have, other extraocular manifestations?
There was no any other extra other than dry eyes, which we came to know secondarily. First was the optic neuritis itself. So there was no other xerostomia or nothing else was there.
Any parotid swelling, submandibular?
Nothing was there.
And how long did you follow up your patient?
Yeah, this is a thing we could not follow it because we lost to follow up this patient. We still hope she comes back to us and we can still investigate her further.
Nice.
Thank you.
What structures are similar between the structures affected in Sjogren's syndrome and the structure affected in optic neuritis?
Okay, so it is the retrobulbar part of the optic nerve which is affected in the as shown in the MRI. However, it is the glandular involvement in cases of Sjogren's syndrome.
Yes.
In case of neurological manifestations, though optic neuritis is a common factor, however, the middle portion or towards the brain, it is more affected, the part of the optic nerve.
You must understand my question properly. I am asking you a specific reason. What structure, microscopically, what structure is similar between the glandular structure in a lacrimal gland which is affected in Sjogren's and the optic neuritis? There must be some similarity between these two for them to be affected one or the other earlier than the other. It's,
If I'm not very sure, sir, but
Okay,
I
that's
think
all.
it is the optic chiasma which
there
is.
for the benefit of others,
Yeah.
the juniors, there is a reason why similar structures are affected in certain cases. You understand?
Yeah.
So you need to go back and look at the anatomy of the lacrimal gland and anatomy of the optic nerve to decide, these two are similar.
Okay.
Okay?
Sure.
Right, good,
Thank
well
you.
done.
Thank you, sir.
Is Dr. Punyaslok Mohanty available? Is Dr. Vidya Verma available? Is your slides ready? Please. Number 5.
No problem.
Good morning, everyone. Thank you, organizing committee, for giving me this opportunity. Here I am presenting clinical and etiological spectrum of the 3rd, 4th, 6th, and 7th cranial nerve palsy. It is a hospital-based cross-sectional study. So as we know, 3rd, 4th, 6th, and 7th cranial nerve palsies cause significant neuro-ophthalmic morbidity. Global incidence are 15 per 1 lakh and 11.3 per 1 lakh, 6th nerve, and 3rd nerve is 15 per lakh. Leading cause are microvascular ischemia, trauma, and neoplasm noted. So aims of this study is to evaluate clinical profile, etiology, demographic of the patient of 3rd, 4th, 6th, and 7th cranial nerve palsy, identify association with risk factor, diabetes, hypertension, trauma, and pattern of isolated versus multiple nerve involvement. And secondary objective was assessment of the anatomical localization of the nerve lesion. These are few patients which we have included: 6th nerve palsy, 3rd nerve palsy, and multiple cranial nerves involvement. So this is hospital-based cross-sectional observational study conducted at tertiary level hospital of the Central India. Ethical approval and consent were taken. 30 patients were included, which were more than 18 years of age. Isolated or combined 3rd, 4th, 6th, and 7th cranial were included. Exclusion criteria were congenital palsy, prior intervention, incomplete record, myasthenia gravis, thyroid ophthalmopathy, myopathies, and multiple sclerosis. Consecutive sampling of eligible patients were done and diagnosis confirmed via detailed history and comprehensive ophthalmic and neurological examination. Demographic data were included and ophthalmological examination, best corrected visual acuity, color vision, ocular motility, diplopia charting, ptosis, ocular alignment, and anterior segment examination, corneal sensation record, and fundus examination, facial nerve evaluation, and other neurological assessment were done. So here we noted 3rd nerve ptosis, mid-diasis, and ophthalmology as sign and symptoms, and 4th nerve vertical diplopia, head tilt, and in 6th nerve horizontal diplopia and esotropia. Additional investigation where there is applicable X-ray, B-scan, CT, MRI, CSF analysis were done, and imaging of localization, enhancement, and anatomical involvement and statistical calculation were done. These are the results. As we can say, there is a mean age were 45.2 and male preponderance were there. And in 7th nerve we have observed that there is a distinct etiological pattern with the trauma and inflammatory causes being more common in younger patients. In contrast, microvascular and ischemic etiology were frequently observed in elder patients. The highest incidence was observed in 40 to 90 group. Bell's palsy was identified as the most common. All cases were treated conservatively, and exposure keratitis was noted in 42% cases, and detailed statistical analysis shown significant association between age and etiology. And 6th cranial nerve palsy, there was a 33.3% of cases, and etiology was trauma, meningitis, vascular in 3rd nerve cases, and multiple cases we have observed 10% of patients, and headache occurred in 2 patients, and there is a etiology were cavernous sinus thrombosis, ophthalmoplasia, and cavernous sinus involvement. So most common palsy was 7th nerve, majority due to the Bell's palsy. 6th nerve palsy was the mainly trauma with the raised intracranial pressure. 3rd nerve palsy is strongly associated with the diabetes mellitus due to the microvascular ischemia, and multiple cranial nerve palsy is most common due to the cavernous sinus thrombosis followed by diabetes, unilateral involvement observed in all cases. So anatomical localization, 7th nerve, lower motor nerve involvement seen, subarachnoidal in 6th nerve, space, and the third nerve subarachnoid space and cavernous sinus was noted, and multiple in cavernous sinus involvement was seen. So our finding align with the global data in some areas, such as the dominance of the Bell's palsy in cranial nerve 7th, and however trauma emerged as a major cause in the cranial nerve 6th, which may reflect regional factor. The strong link between the diabetes and cranial nerve 3rd palsy emphasized the need of the metabolic control. Cavernous sinus thrombosis remain a critical diagnosis in multiple nerve involvement. So the strength of this study was prospective and comprehensive evaluation, and there was a small sample size. And so I conclude this study as a cranial nerve 7th palsy was most common with Bell's palsy, and cranial nerve 6th was often trauma related. 3rd is shown strong ties to diabetes. Cavernous sinus thrombosis was key in multiple palsies, and these insights can guide clinician in early diagnosis and systemic evaluation, ultimately improving patient's outcome. Thank you so much. These are references.
It's a good study with limited sample. That is your drawback, that it does not have enough sample size.
Yes, sir.
See, in any study earlier, before 2000 and all, the sample size was not very important in drawing a conclusion. But after 2000, they realized that nearly 1/3 of the papers published before 2000 had inadequate sample size, and therefore their conclusion need not be applicable. You understand?
Yeah, right.
So for oral presentation, these are okay, but if you want to take it
Publish
for presentation in a paper, it's important always to calculate the sample size.
Yes, thank you.
Yes?
So
Good.
in
there any-
continuation with what Sir said, in that case, then you can treat it as a case series rather than a study, because then you're still allowed to report it. And also 6th nerve is known to be the most commonly affected
Very
for trauma.
common.
Can you say why? Can you tell us why?
Microvascular causes. Due to diabetes, microvascular causes.
Trauma, you said.
Yeah.
6th nerve is most common for trauma. So why is that?
Yes.
Why? Ma'am is asking why in trauma 6th nerve is commonly affected.
Because it's because of location actually. So or head trauma and orbital trauma it may induce.
Is there any particular
Read it
reason you have excluded certain conditions like myasthenia, multiple sclerosis? Was there anything in the mind why you have excluded those conditions?
Because there is a systemic correlations, so we didn't evaluate this. We mainly focus on the ocular involvement and ocular causes.
Okay.
How many are postgraduates here? Any postgraduate? Very good. For the benefit of postgraduates, you remember any isolated 6th nerve palsy, if it does not recover within 3 weeks, then only you go for neuroimaging. Within first 3 weeks, there is no need to go immediately for neuroimaging. You will not find anything wrong at all. You just waste money and the resources of the country by doing MRI. The first thing they notice is MRI for 6th nerve. Don't do MRI in 6th nerve palsy if the fundus is normal. If there is no papilledema and you notice 6th nerve palsy, don't do MRI. But if you notice papilledema in both the eyes, do immediately. Okay? Right. Who is the next
And
person?
classically, the neurologist will call this a false localizing sign also, right?
Next, I would like to call Dr. Asta Thakur.
Alka Gupta is here.
Good afternoon everyone. I am Dr. Asta Thakur, second year PG resident, presenting my work on pilot study on OCT and vision testing for early detection of ethambutol toxicity in tuberculosis patients. As we all know, ethambutol is a first-line ATT drug essential for preventing drug resistance. It carries risk of ethambutol-induced optic neuropathy. Early signs include changes in contrast sensitivity, color vision and visual fields. Best corrected visual acuity often remains normal initially. With OCT, especially ganglion cell inner plexiform layer analysis, early structural changes can now be detected, enabling timely diagnosis and prevention of irreversible visual impairment. With this background, the aims and objectives of the study were to estimate the incidence of ocular toxicity of ethambutol in diagnosed cases of TB undergoing ATT under National Tuberculosis Elimination Program. Second was to assess the role of OCT and optic nerve function test for early detection of ethambutol toxicity. Study center was Department of Ophthalmology, SSMC Riva. Study design is prospective observational cohort study, and study population includes 70 newly diagnosed TB patients. Inclusion criteria: all diagnosed patients of TB taking ethambutol. Exclusion criteria were patients with pre-existing ocular disease such as glaucoma, optic neuropathy, or any significant retinal pathology, history of intraocular surgery other than cataract surgery, best corrected visual acuity less than 6/12, pre-existing visual field defects, history of intake of non-ethambutol drugs known to cause ocular toxicity. Procedure included comprehensive ophthalmic evaluation at baseline, 4 weeks and 8 weeks after initiation of ATT. Visual acuity was measured using Snellen's chart and converted to logMAR units. Color vision assessed using Ishihara plates. Contrast sensitivity tested using Pelly-Robson chart. Amsler grade was used to detect metamorphopsias or scotomas. Visual field assessed using HFA 30-2 program in symptomatic patients. OCT was done to assess peripapillary RNFL thickness and GCIPL macular analysis. Results were measured in functional and structural parameters. Among functional parameters, color vision defect was seen in 12.9% patients. Contrast sensitivity decline was seen in 17.1%. Amsler grade abnormality was seen in 7.1%. Though the visual acuity remained stable, visual field defect was seen in 4.3% of the patients. Among the structural OCT parameters, RNFL thinning mainly in the temporal quadrant was seen in 14.3% of the patients, and ganglion cell inner plexiform layer thinning was seen in 11.4%. Though GCIPL thinning preceded RNFL loss in some patients, overall the cumulative incidence of at least one abnormality within 8 weeks was 45.7%, with 95% confidence interval of 34.6 to 57.3%. Observed incidence was significantly higher than historical, which shows that the study is statistically significant. Discussion: ethambutol-induced ocular toxicity can occur within first 8 weeks even when best corrected visual acuity remains normal. Functional tests, which include contrast sensitivity, color vision, detected early abnormalities more frequently than OCT. Among OCT parameters, GCIPL analysis emerged as an earlier indicator compared to RNFL thinning, reinforcing its role as a sensitive biomarker. Findings are consistent with earlier studies corroborating the benefit of combined monitoring. Integrating low-cost functional tests with targeted OCT evaluation may allow timely detection and prevention of irreversible blindness. I conclude my study with regular and early monitoring is essential during the initial weeks of ethambutol therapy. Normal visual acuity does not rule out toxicity. Subtle functional and structural changes appear first. Simple chairside tests like contrast sensitivity and color vision with targeted OCT can detect changes before vision loss. So early detection allows timely drug modification and prevents irreversible blindness. A practical screening tool can be integrated in routine TB care under National Tuberculosis Elimination Program. Limitations were single center study with small sample size, and the follow-up period was short, so the long-term outcomes could not be assessed, and OCT availability may limit use in peripheral settings. These are my references. Thank you.
Good. My question is, did you record logMAR visual acuity on a logMAR chart, or you recorded Snellen's visual acuity and that's mentally converted into logMAR chart?
Sir, we recorded Snellen's visual acuity and then it was converted.
Okay, you have recorded Snellen's and then divided and then calculated the logMAR and converted. Is there a difference of just doing Snellen's acuity and then converting it to logMAR and recording on logMAR chart a visual acuity? Do you think there will be a difference? There will be a difference because of the effect of crowding phenomenon. There will be a difference between the two. A 0.00 on logMAR is not exactly 6.6 on
Snellen's.
You understand? That's 1.1. The point 2, those cases you have excluded from the study. are the ones who already have visual acuity problem due to other causes, and they may also be on ethambutol. If they are, then how do you conclude anything in these patients? Supposing a cataract patient or some other problem patient comes to you with reduced vision, but he is also on ethambutol. Now, how do you differentiate whether it is due to ethambutol or due to the earlier pathology which was already existing?
That is exactly what I was going to raise, that then you should do a pre and post study in the tubercular patient before he starts the treatment and after he starts the treatment, and on ongoing treatment also.
Yes.
Yes, ma'am, it was
Because
done.
on the first week you may not have the toxicity, but you may have after a few weeks,
Only those patients were included which were starting, like which were newly diagnosed.
No,
so
no, you have only
So did you
proved
take
that
pre and
ethambutol
post?
toxicity can occur and lead to visual loss in about 8 weeks' time.
uh,
Is this a fact which was not known to anybody? It was well known fact, correct? Ethambutol toxicity does occur is a known fact. Now your idea is to try and prove that ethambutol toxicity can occur in some patients where OCT, ganglion cell layer is, assessment of ganglion cell layer is helpful compared to the other OCT. How many of you know that the ganglion cell layer can be assessed with Heidelberg OCT? Very few, correct? So the point you have to drive is that if you do OCT in ethambutol toxicity, you must look at the ganglion cell layer first. And the ganglion cell layer is affected first even before the optic nerve area, because essentially it's a ganglion cell problem. The optic nerve area is just the axon. So cell body is affected and takes some time for the effect of cell body's death to reach axon. Optic nerve is just a collection of axons. You understand? Good.
So like sir said, then in that case, what type of OCT, or you'll do a segmentation, OCT segmentation for the ganglion cell layer. Another thing is that you could have had a control population of the same age matched controls, because these are young patients usually. Those who have TB are young patients. In young patients, our retina specialist will always tell us there'll be a slightly OCT disc, there will be a slight elevation of the disc. So you never know that an age match control would have had the same findings. So that is something that you really need in this particular case, especially when the age group is younger side. Okay.
Is there a correlation between OCT macular thickness and vision?
Sir, vision was, in my study, vision was
No,
actually
I'm asking
stable.
you a general question, nothing to do with ethambutol toxicity. Is there a correlation between the vision and foveal thickness or macular thickness in OCT? There is
Yes,
or there is not, or there may
Sir,
be?
there is.
There may be. The answer is there is not is incorrect, there is incorrect, there may be is correct. Okay, fine, thank you. Well done.
Thank you, sir.
Who is next?
Is Dr. Bhavana Chaudhary there? Dr. Priyanka Mishra? Yes.
Good afternoon, everyone. So today I'm presenting my paper on addressing the ethambutol toxicity and visual benefits of oral pentoxifylline and optic neuritis. So we know ethambutol is a first-line TB drug, and it acts by inhibiting the mycobacterial cell wall synthesis and causes retinal ganglion cell apoptosis. And we appreciate temporal disc pallor due to vulnerability of papillomacular bundle. The onset is more within 3 to 5 months of use, and the risk increases with more than 15 milligram per kg of dose. The presentation may be subacute, bilateral, and painless central loss of vision, and it may be asymmetrical. In the early stages, pupil may be normal, while in advanced, we can appreciate RAPD. Initially, fundus can be normal, but later on, peripapillary hemorrhages, disc pallor, and color field defects can be seen. On perimetry, we appreciate central or centrocecal scotoma with decrease in contrast sensitivity, RNFL and retinal ganglion cell thinning in on OCT, and on VEP, P100 amplitude and latency abnormalities can be seen, and it is an early biomarker. We know pentoxifylline is a synthetic dimethylxanthine phosphodiesterase inhibitor which increases the CAMP and improves the microcirculation, thus stabilizes the endothelium and reduces the autoimmune response. It is also found to have neuroprotective action. So it is well absorbed orally and the peak absorption is between 2 to 3 hours. The bioavailability is 20 to 30% due to its high first pass metabolism, and it is converted into active metabolites in liver and erythrocytes and mainly excreted through kidneys. It is given in a dose of 400 milligram extended release oral tablets. So the aim and objective of my study was to assess the role of oral pentoxifylline in ethambutol induced optic neuritis. It was conducted in Department of Ophthalmology at a tertiary care center between September 2022 to June 2024. It is a prospective interventional study which included patients on ATT or recent ATT with ethambutol-induced optic neuritis and willing for participation and follow-up. Those unwilling for follow-up had other optic neuropathies or recent cerebral hemorrhages were excluded. A total of 34 patients with 68 eyes were enrolled in the study, with intervention group A, which received oral pentoxifylline 16 to 18 milligram per kg body weight along with vitamin B complex for 6 months, and group B received only vitamin B complexes for 6 months. The follow-up and assessment was done for a duration of 6 months, and it was assessed using BCVA, contrast sensitivity, color vision, fundus examination, and VEP. So the results in our study, in group 1, the maximum patients were more than 50 years of age, and in group 2, it was between 31 to 40 years. Female preponderance was noted in both the groups. Improvement of vision in group 1 was 0.71 plus minus 0.21, while in group 2 it was 0.21 plus minus 0.07. On subsequent visits, there was a significant difference in improvement in vision among the groups with a p-value of 0.001. On contrast sensitivity, there is in group 1 0.697 improvement was there, and group 2 0.106. And on subsequent visit, the difference among the two groups was found to be statistically significant. The VEP changes is in group 1 minus 4.18 and in group 2 4.67. And color vision changes was not found to be statistically significant among the two groups. The duration of ATT intake among the two groups was found to be statistically significant. Was not statistically significant, so the two groups were equivalent. So in our study, we included 68 eyes with ethambutol-induced neuritis, and female preponderance 62% was noted, with 10 patients more than 50 years of age. So similar studies have been done where it was found female preponderance is noted. So females have higher antioxidants in reproductive age, which declines post-menopausal age, so which may explain this finding. And the interventional group, we observed significant improvement in vision, contrast, VEP latency with oral pentoxifylline, while in control groups, no such improvement was seen. So we conclude that ethambutol optic neuritis may be irreversible, especially in older patients more than 60 years of age. So it is a prospective study which objectively measures BCVA, contrast vision, color vision, and VEP, while it is a small sample size and single center study with a short follow-up. So, but it does implicate that pentoxifylline along with vitamin B complexes may improve vision, contrast, and VEP, and early intervention definitely prevents vision loss. But there is a future scope of larger multicentric trials, longer follow-ups, and study of gender or age differences. Thank you.
So what you are saying is ethambutol toxicity is a ganglion cell problem or is optic neuritis?
So there are changes.
No. There are changes in the optic nerve, yes. But the ethambutol toxicity is primarily an optic nerve problem or it's primarily a ganglion cell problem?
Sir, it causes apoptosis of retinal ganglion cells.
Primarily a ganglion cell problem. The optic nerve manifestations are secondary to the ganglion cell loss.
Yes.
Now, what happens in ethambutol toxicity to the ganglion cells?
Sir, mitochondrial enzymes are involved because ethambutol is known to cause chelation of mitochondrial enzymes, complexes 1 and 4.
Okay. Why is there a ganglion cell damage in ethambutol toxicity? You need to read a lot about that. I'll tell you later on. Now, in ethambutol toxicity, what happens is there is a hyperexcitability damage to the ganglion cells. The hyperexcitability damage to the ganglion cell is due to nitric oxide that is released, excessive glutamate that is released at the ganglion cell. Now the excessive glutamate in the extracellular cells is inimical to the cell, neural cell. That's what happens. And with the ganglion cell, the specialty is that if one ganglion cell dies, the surrounding ganglion cells commit suicide. It's called ganglion cell autophagy. They all die at the same time. But ethambutol toxicity, the color vision ganglion cells are stronger and they survive for a longer time than the ordinary vision ganglion cells. Unlike in heredomacular dystrophy, where the color vision cells get damaged early and the normal vision cells get damaged later, it's the reverse of that in ethambutol toxicity. Okay, good, well done.
Thank you, sir. Thank you.
Next is Dr. Meghna Dikshit.
Good afternoon, everyone. I'll be presenting my free paper on the topic Clinical Profile and Management Pulse of Optic Neuritis in a Tertiary Care Center of Eastern India. While we all know that optic neuritis is an inflammatory disease of the optic nerve that typically presents as sudden visual loss and pain on eye movements, the worldwide incidence of unilateral optic neuritis ranges from 0.94 to 2.18 per 1 lakh population per year. And corticosteroids have been used for the treatment of optic neuritis since these drugs were introduced into the clinical practice. The very famous ONTT trial we all know that was conducted in the 1980s have already given us all the answers. That does treatment with either oral prednisone or intravenous IVMP followed by oral prednisone improve the visual outcome of optic neuritis? Does either treatment speed recovery of vision? And are the complications of treatment insignificant in relation to the magnitude of treatment affected? And the aim and objective of this study was it aims to determine the clinical profile and treatment outcomes of optic neuritis patients with 1 gram of IVMP for 5 days. The specific objectives included documenting patients' demographics, characterizing the optic disc changes seen on fundus examination, and assessing the changes in visual acuity before and after corticosteroid treatment. Through these objectives, the study sought to provide a clear picture of how patients with optic neuritis present in this region and how they respond to the high-dose therapy. A prospective study of optic neuritis patient carried out at Neuro Ophthalmology department of our hospital from January 24 to January 25. All patients underwent a full ophthalmic assessment including visual acuity, color vision, contrast sensitivity, slit lamp biomicroscopy, dilated fundus examination, visual field testing, and routine laboratory workup. All patients were subjected to MRI brain and orbit, and a neurologist opinion was obtained in suspected demyelination patient. Inclusion criteria for the study was symptoms present for less than a week, complaints of unilateral or bilateral sudden loss of vision. If exclusion criteria included any history of trauma, and all patients received IVMP 1 gram for 5 days followed by oral prednisone for 11 days and gradually tapered over a 10-day tapering period. The demographic details we obtained in our study was 12 females, which were and the major population was around 21 to 40 years, demonstrating that most of the patients were young females. Optic disc changes, around 8 discs were normal in appearance, and the visual acuity changes before and after treatment was the logmar acuity. 25 eyes had 0.05 better vision. In this study, 28 eyes were included. Their mean age was 35.34 years and 52.17 optic neuritis patients were female. The study findings are consistent with the previous literature showing that optic neuritis is more common in young adults and female patients. Kachlin et al. Reported that they examined clinical predictors in optic neuritis and concluded that being older, being male, and having worse visual function at the beginning posed a risk for worse clinical outcomes. This study also found that the patient with an attack of retrobulbar optic neuritis had a better visual prognosis than patient with edematous disc. This may suggest that retrobulbar optic neuritis may generally be associated with milder inflammatory processes, and patient had defective vision and contrast sensitivity at the time of presentation in the study by Faruzin et al. In our study, 66 percent eyes had impaired color vision, and in the rest it could not be assessed due to poor vision. While ONTT reported that most patients recovered about 2 lines on the Snellen chart within 2 weeks, the patient in this study showed that more than 3 lines of recovery in the same period. These findings align with prior research by Fernando et al., who concluded that we should consider a 3-day regimen for mild cases and 5-day regimen for severe cases. This suggests that the use of 1 gram of IV MP for 5 consecutive days may be more effective in achieving faster recovery. However, ONTT provided long-term data on recurrence rate and multiple sclerosis risk, which are not assessed in the present study due to shorter follow-up. Thus, we conclude that vigilant clinical workup and aggressive IVMP regimen for 5 days can lead to faster and early return of visual acuity. Patients with retrobulbar neuritis showed a more favorable prognosis compared to anterior forms, a finding useful for clinical counseling. Thank you.
How have you, when you said, can you just go back? Actually, you cannot go back. Right. Okay, fine. So it's very interesting. No, is there any data which suggests that you can, which other protocol, is there a modified protocol which exists in addition to the ONTT? Was my question. There's another protocol also that exists for optic neuritis. So are you following that, or are you merging the two, or what are you doing?
So, ma'am, we try to merge the two of them. And
which is the second one called? Okay, thank you.
Next, we would like to call Dr. Prerna Ahuja.
Good morning, respected faculty and colleagues. I'll be presenting a case series of cranial nerve third palsy, which I've presented to our Squint clinic over the past 1 month. So, in general, what are the causes of third nerve palsy? In adults, it can be systemic causes like diabetes, hypertension, vascular ischemia, any history of trauma, intracranial neoplasm, intracranial hemorrhage. It can be congenital, idiopathic, or due to myasthenia gravis. In pediatric age group, 43% of these cases are congenital with 13% local inflammation, 20% of these cases are traumatic, and 7% due to any intracranial aneurysm. Migraine are also a cause in pediatric age group. So I'll be discussing some clinical cases that we have seen. First is a case of uncontrolled diabetes associated with left third nerve palsy. It was a 52-year-old male with ptosis for 25 days with binocular horizontal diplopia since 2 days. On examination, there was a head posture of 20-degree face turn with the 40 PD left exotropia. For diplopia, the patient was patched. Patching was advised and a repeat endocrine reference was done. The patient followed up after 20 days with only residual 10 PD exo in primary gaze. The patient is generally improving, which is the general course we see in patients of uncontrolled diabetes with third nerve palsy. It can be seen due to post-tubercular cases. A 10-year-old girl presented with complaint of outward deviation of right eye since 2 months. It was gradual in onset, associated with diplopia. She was already on ETT for multiple intracranial tuberculomas since 1 month from the pulmonary department with no associated history of seizures. The patient was worked up, the ATT was continued, and we have kept her under 3 weekly follow-ups. However, no significant improvement has been seen. We have had only 2 consecutive follow-ups for this patient till now. This was a case of a post-herpetic zoster bilateral cranial nerve third palsy. The patient had history of herpes zoster 1.5 years back, has roamed around everywhere with opinion, with outward deviation of right eye subsequently during the resolving phase of herpes zoster. 2 follow-up visits were done for this patient where the exotropia remained consistent of about 70 PD. However, the cornea was not good. There were residual PKs in these follow-ups, so we delayed the surgery till the cornea improved. For which we gave Lactogel ointment with nighttime lid taping. We ultimately planned the patient for surgical correction under oral acyclovir cover-up to manage the flare-ups. It was given for 2 weeks, 400 mg BD, and continued till 1 week post-surgery to prevent any flare-up, and good results with central HBCR were obtained. He was a happy patient. The surgery was done in 2 stages because it was a large exo. Post-traumatic, this is a case of post-traumatic third nerve palsy. This is a representative image. The actual image could not be, at the time of intervention, could not be taken. The patient had history of road traffic accident 2 months back with the history of exovitosis in right eye. There was history of improvement as per in the deviation as per the patient. And the NCCT at the time of brain injury documented was normal. The patient was advised a repeat MRI after 2 months, but was however lost to follow-up. This was only included to show the myriad of presentations that we can have with third nerve palsy. Another patient, diabetic with ischemic bilateral third nerve palsy, presented with acute onset diplopia with outward deviation of right eye since 5 days with no known comorbidities. On examination, she had a bilateral third nerve palsy. She was first, when we advised her investigation, she was diagnosed to be a diabetic patient and was referred to the endocrine department. The patient was started on insulin and is now slowly improving. So overall clinical features of third nerve palsy can be ptosis, down and out eye, which due to the sparing of lateral rectus and superior oblique. Pupil can be pupil involvement I'll be discussing, and then there can be diplopia. Pupil involvement can be due to in compressive pathologies, the pupil will be fixed and dilated due to sphincter nerve palsy, and in ischemic cases pupil is generally spread. The accommodation is not lost. So when there is a pupil sparing palsy, you have to do a systemic workup with blood sugar, pressure, CBC and ESR. For pupil involving, it's a medical emergency, you have to do a MRI and CT. Third nerve palsy can have false localizing signs, which is the Carnoha-Notch phenomenon. In Hutchinson's pupil, there is a unilateral fixed dilated pupil. Due to an intracranial lesion, there is transtentorial herniation of the brain, uncal herniation, which compresses the oculomotor nerve against the free edge. So on the same side, the pupil is involved, and the hemiplegia happens on the opposite side. So management of these patients for acute palsy, diabetic, hypertensive, you have to manage these. You have to follow these patients up every 3 months. And ischemic third nerve palsy mostly improve within 1 month with complete recovery in 3 months, no surgical intervention till 6 months. If diplopia, patient symptomatic, you always patch the affected eye and alternate patching if it's a child. And Botox can be used for lateral rectus. Surgical management, you resect the medial rectus and recess the lateral rectus for horizontal deviation with superior oblique transposition if required to keep the eye in primary position. And for pupil involving, you have to urgently refer the patient to a neurologist. Thank you so much.
What is the
Show
reason
me
for
that bilateral third nerve palsy which you had diagnosed. You know, there's one picture with bilateral, you said bilateral third nerve palsy.
Yes, sir. So it was in...
No, show me the picture.
I think from there only they can.
You ask them to show that slide again. Show the slide again.
Presentation once again.
Presentation. Keep going forwards.
Yes,
I'll tell you when to stop.
Yes,
Go
sir.
forwards. Which is the
female
bilateral
patient.
one?
Yes, sir.
Ah.
So sorry.
Stop it there. If I say the diagnosis here is webinar syndrome, how do you disprove my diagnosis? If I just tell you, no, it looks more like bilateral internuclear ophthalmoplegia. If I say that, how do you disprove my diagnosis? Do you understand?
I understood, sir, but
So if I tell you it is bilateral internuclear ophthalmoplegia, do you say I am incorrect or do you say it may be? And if you say it may be, then how do you
so pupillary reaction
then
involvement
you disprove
will
yourself by saying it's a bilateral third nerve
so
palsy
differential.
in diabetes.
So Webino syndrome will have mostly pupil
No, the
reaction
reason I am
involvement.
asking you is very simple. For a bilateral third nerve palsy to happen, the two nerves are in two different places. It's very difficult for a microcirculatory lesion to be exactly in the same place in two different parts of the brain. But for an internuclear ophthalmoplegia to happen, they can be very close. Can you trace the internuclear fibers between third nerve and sixth nerve?
So PPR. What would you
No,
please-
no. Between
sir,
third nerve, PPRF is paramedian pontine reticular formation, which is nothing to do with third nerve.
so-
How do you, can you trace the internuclear fibers between third and sixth nerve? It's
Sir,
a
I-
medullated fiber or a non-medullated fiber?
So these are non-medullated fibers.
No, you're wrong. It is medullated because that's why it's affected in multiple sclerosis first. You understand?
Yes, sir.
It has to be medullated because the impulse has to go. Okay, before I tell you that, the impulse goes in the internuclear fibers from sixth nerve to third nerve or from third, it descends from third to sixth. It ascends up from sixth nerve to third nerve or it descends from third nerve to sixth nerve.
So from third to sixth.
Huh?
Third to sixth to third. It from below to up.
It is an ascending,
Ascending
tract or a descending tract. You're not sure?
Sir, I have not
Okay,
revised.
no problem. That's
Sorry.
the reason why you
Sorry.
need to know all these aspects in neuro-ophthalmology is because this is medullated going from sixth to third, not from third to sixth. It's not a descending fiber. Most of the fibers from the brain are descending fiber. This is one of the only fiber which ascends from sixth to third. And it has to be medullated because there has to be a rapid conduction. Since it is affected in multiple sclerosis very early, it can be multiple sclerosis also. It's not unusual to have multiple sclerosis in India. So when you see a walled eye syndrome, then you should think of multiple sclerosis as the first diagnosis. You can close your eyes and say this is multiple sclerosis, not a. Is pupil likely to be affected in these cases?
Pupil will be affected if
In
it's
multiple sclerosis, walled eye phenomenon, is the pupil affected or not affected? It can be affected,
yes,
need not
can
be
be
affected depending on the whether it is a rostral or it is in front. Oh, never mind that. Those are all the things you need to know. So if you know exactly the features, you don't need MRI. You can diagnose looking at some points, you can say lesion is more like. When you ask for MRI, in Saudi I used to work, there were neurologists who used to ask MRI from brain to spine. From brain to spine. I said, why you left out left leg? You ask up to left leg. That is where the problem is. So if you know where the lesion is, you can tell the radiologist, please look for the lesion in this area. And to know the lesion, you need to know the neuroanatomy well. And to know the neuroanatomy well, you need to read. Any amount of reading clinical ophthalmology will not help you understand neuroanatomy. Correct? You have to read neuroanatomy. So please read your
yes, I'll read.
volume 3, Cunningham volume 3.
Yes.
Okay, fine, good. Anyone else? Any questions here?
What is the reason for
Good.
And my only suggestion is that again, this was a very diverse group of cases. You cannot make it
Yes.
into a study, but like a case series, it's okay.
So just
Thank you.
1 month,
Yeah.
whatever patients
Yeah.
I could find.
Thank you. Next, we would like to call Dr. Ridhima for the keynote address.
You have exactly 5 minutes.
Yes.
Which one is?
Good afternoon, everyone. I'm going to present an interesting case about a 29-year-old gentleman who's an IT professional living in a densely populated locality in North India. Came to me with ongoing fever for 7 to 10 days with sudden onset painless diminution of vision in the right eye for 3 days and central black spot in the front of the right eye for 3 days. So the history of presenting illness, the patient was apparently well a few weeks back when he complained of low-grade fever, which was insidious in onset, undocumented, and reduced on treatment with paracetamol. It was not associated with any evening rise of temperature or chills and rigor. He developed diminution of vision 3 days ago, which was associated with a central black spot in front of the right eye, single, stationary, and non-progressive. There was no significant history of trauma, distorted images, tinnitus, flashes of light, any previous ocular history or exposure to pets, stray animals, or any history of systemic illness or significant family history. However, his past history was slightly significant. Patient had hypopigmented patches on the right eye lower lid, along with 2 patches on the right side of the face. He was diagnosed as segmental vitiligo and started taking treatment from a local practitioner. Previous documents suggest that he was on long-term steroid treatment for the same lesions, and the lesions were static and non-expansile, non-pruritic, with no history of reduced sensations over the patches. These are the vitiligous patches. So there was no significant personal or family history. I came to the general examination where his temperature was slightly raised, the rest was insignificant. Coming to his ocular examination and the positive findings I saw was unaided vision was 20 by 400. The projection of rays was accurate in all quadrants. His color vision and near vision both were defective. Contrast was reduced, and on the eyelid adnexa, as I said, had poliosis of the lower lid lashes. So there was relative afferent pupillary defect grade 2 on the neutral density filter with anterior chamber cells but no flare. Coming to the fundus examination, which was significant on distant direct, I saw both eye fundal glow. On slit lamp biomicroscopy, there was the disc which was which had obliterated obscured margins. There was striae that was seen on the macular area with dilated tortuous vessels of the right eye, whereas the left eye had non-significant findings. Coming to the OCT macula, I saw distorted foveal contour. There was intraretinal cystic lesions that were present with neurosensory detachment of the macula. The left eye's OCT macula was absolutely normal. Coming to the OCT RNFL, I saw the average thickness which was raised in the right eye and the left eye, it was normal. So I came to the differential diagnosis of right eye neuroretinitis with vitiligo. So I could easily be confused with ocular tuberculosis, and the vitiligous patches confused me with Wojtkowiak-Harada syndrome. But going to further examination, I saw that investigation proved ESR to be high. The Montu test had 30 mm of induration, and antibody for Bartonella Hensley IgM serology was positive and was significant. It had IgM levels of 1:640. The CECT chest and HRCT had few bilateral lung fibrosis in bilateral lung field, which was suggestive of old infective sequelae. So my working diagnosis came to right eye neuroretinitis due to Bartonella species, and I started the patient with oral doxycycline of 100 milligrams twice a day for 2 weeks. So the patient was followed up in 1 week, and his vision improved to 20 by 200 from 20 by 400. He was reevaluated on the second week, and a whooping vision came back to 20 by 30. With a continued treatment, color vision came back to normal, and pupillary reaction also came to normal. These were his clinical pictures. We can see the macular exudates that were post the inflammation. The retina had settled, the neurosensory detachment had settled. Only a few hard exudates were seen intraretinally. So the OCT RNFL findings, as we can see, average RNFL came back to normal. And these were his visual fields, which earlier had scotomas. Could not put a picture of it, but improved on our treatment. Follow-up was done, and the patient was continued with oral doxycycline of 100 milligrams twice a day for the next 4 weeks, and a total treatment of 6 weeks were given. Patient is still following up with us, and he's absolutely fine. I would just want to say that serology is very rarely used, especially for IgM, in India because of the TB burden. We always suspect tuberculosis, and in such a case where vitiligo was present, and we had to also rule out weak age, but clinical age profile, male gender kind of ruled that out, and that's when we actually went for IgM serology. So even though it's a slightly expensive test of about 20,000, it's worth a try, and we could see better improvement. Also can avoid ethambutol toxicity that we would put a patient through with TB treatment. Thank you.
Very good. Anyone who has not presented now, till now?
Dr. Bhavana has come up now. Dr. Punyaslok Mohanty. I think they are not there.
So if the others haven't come, we can conclude the session. I would request all the speakers to join us for a photograph.